Good morning all, and thank you organizing committee for the opportunity. My topic will be registered data on long-term morbidity after prostate ultra-hypofractionation in the HYPO-RT-PC trial. So the registered data is presented as a proffered paper in ISTO 2024, and the trial was presented in 2019 in the Lancet Oncology. So it was an open label randomized phase 3 trial. It was the first trial testing the ultra-hypofractionation in the prostate cancer. It was a multicentric study done in 12 centers in Sweden and Denmark. The primary endpoint was time to biochemical or clinical failure analyzed in the per protocol population. The pre-specified non-inferiority margin was 4% at 5 years. The physician recorded toxicity was measured according to the RT-OG morbidity scale, and patient reported outcome measurements was done with the PCSS questionnaire. Secondary endpoints were the biochemical disease-free survival, clinical disease-free survival, prostate cancer-specific survival, overall survival, and the quality of life and the toxicities. So if we see the trial design, it is equally distributed designs in the both the arms. That's the conventional fractionation arm, which gives the radiation dose of 78 gray in 39 fractions over 8 weeks, and the ultra-hypofractionation arm, which gives 42.7 gray in 7 fractions, 3 fractions per week over 2.5 weeks. So both the arms contains around 600 patients. They are equally distributed in terms of the Gleason scores, in terms of the staging of the prostate cancers. They include mainly the early intermediate stage cancer, that is 89% of cases were intermediate risk and only 11% were high risk. Even the techniques used in this trial for giving radiation, that is the conformal and IMRT and VMAT techniques, are equally distributed in both the arms. See, the median follow-up, which was presented in 2019, it was for 5 years, in which they showed that failure-free survival in both the arms were similar, that is 84% for both the arms. There were 102 primary events in the conventional fractionation schedule, and 100 were in the ultra-fractionation schedules. So PSA relapse was detected in 1933 patients, local recurrences in 6 patients, and distant metastasis in 3 patients in both the arms. So there was no significant difference in the overall survival at 5 years. That was 96% for conformal radiation therapy, conventional radiation therapy, and 94% for the ultra-hypofractionation. Considering the urinary toxicities, there was weak evidence that acute urinary toxicity was more for the ultra-hypofractionation arm, that is 28% versus 23% for the conventional arm. There was no difference in grade 2 or worse toxicities considering urinary or bowel toxicities in both the groups at any point of time, except for the urinary toxicities, which was higher at the end of 1 year for the ultra-fractionation arm. So compared to conventional fractionation, it was 6%, and in ultra-hypofractionation arm, it was 6%, and conventional fractionation, it was 2%. The physician recorded cumulative late urinary toxicity was 18% in the ultra-hypofractionation arm and 17% in the conventional arm at the end of 5 years. So similar with the bowel toxicities, in both the arms, the bowel toxicities were not different at the end of 5 years. So erectile dysfunction decreased from almost 70% at the start of radiotherapy to 35% at 5 years, which was similar for both the arms. So the same paper was again evaluated with the registered data, and the data were assessed from the prostate cancer database from the Sweden and Denmark. And the registries, the national registries were evaluated, and they were compared with a population-based control group of men without prostate cancer. The ratio was 5:1. They compared the trial patients versus the normal population with the similar age group from the same country. And the data was presented in the ISTO 2024. So the primary outcome for this evaluation was medically significant GU and GI events that were considered potentially RT-related and mortality associated with these outcomes. They divided it into the broad code set and the narrow code set. Broad course set, they gave the directly or indirectly represent any adverse event relevant to prostate RT, that is acute kidney injury or acute bowel injury. And the narrow course set includes the adverse events strongly related to prostate RT, that is proctitis. The secondary outcomes were need for minor GU interventions like catheterization or grade 2 toxicities or use of any antispasmodics. All the data were collected from the registered file of the patients. And all outcomes were analyzed at the time of first event from start of RT with censoring at death, immigration or before March 2023. The control group was also censored if it was detected with the prostate cancer. So 544 patients from the trial were included from each group, each arm, and 2,705 matched men without prostate cancer were compared. And the median follow-up was 10.7 years. So this is a long-term data. This is the first randomized trial which is showing such a long-term data after 10 years, and in which for broad code set, they have seen both the arms, the ultra-hypofractionation as well as the conventional hypofractionation has shown similar effect. That means for genitourinary toxicities, it is 17% and 19% for the trial arms. And when they compared with the control arms without prostate cancer patients, it is 9%. For narrow code set, that means up to grade 2 urinary toxicities, it is 9% for the both arms and 4% in patients in control arms. When they compared the gastrointestinal events for broad set, it was similar, and it was 10% for the control arm and around 17% for the ultra-hypofractionation arm. Even the narrow code set for gastrointestinal toxicities, it was similar for both the ultra-fractionation as well as the conventional fractionation. So from these data, they concluded there were no significant difference in the cumulative incidences between the ultra-hypofractionation or conventional groups for any of the primary and secondary outcomes. Excess GU and GI toxicities were only 4 to 10% when they compared these toxicities with the control arm. The mortality from the GU and GI conditions at 10 years was low, that is 1.3% for the broad code categories and 0.1% for narrow categories. And it was 1.8% for the control arm, which was not having the prostate cancer. So routinely collected health data support the trial findings similar long-term GU and GI morbidity. Excess GU and GI morbidities are ranging from 10 to 10% compared to the control arm, and no excess mortality from the GI or GU conditions after radiation therapy. So this, the 10 years outcome data of the HYPO-RT trial were also presented in ISTRO 2025. The media, it was released in May only. So it has shown after 10 years, the failure-free survival was 72% in the short course group versus 65% in the standard group. Overall survival was 18% for short course and 79% for the standard arm. Prostate cancer specific mortality was 4% in both the groups. The side effects were mild to moderate and equivalent for both the ultra-hypofractionation as well as the conventional fractionation. The limitation for the HYPO-RT trial at 2019 was the short-term data, but now in 2025, the 10 years results are published. I think this is the randomized trial with the highest sample size, which is showing similar efficacy. So for many patients, radiotherapy is a standard treatment option that offers outcome comparable to surgery, particularly for localized disease. A significant shorter course of radiotherapy for localized prostate cancer is just safe as and effective as the traditional 8-week schedule, even after 10 years of treatment. For patients, this means less disruption of daily life, potentially lower healthcare cost without compromising the outcomes and the safety. These results demonstrate how modern radiotherapy approaches can make treatment more efficient, accessible, and patient-friendly without sacrificing the effectiveness and safety. Thank you.
Thank you, Dr. Dipali.